Everyone okay over there? Good morning, and thank you to the TVS for inviting me here to speak to you today about complex regional pain syndrome. Just a quick question, has anybody heard of CRPS? How many? Wow. Yeah, not bad, maybe 10%, pretty good. Okay, well, my name is Victoria Abbott Fleming, and in November 2003, just 1 year after being trained as qualified as a barrister in the United Kingdom, I had an accident at work. I slipped down 30 concrete stairs and suffered major soft tissue injuries to the lower limb. That I thought was it. However, unfortunately, 7 months later and 39 specialists and doctors later, I was diagnosed with complex regional pain syndrome, or CRPS. The CRPS unfortunately grew to such an extent that leg ulceration and skin breakdown happened and occurred on both legs, but 8 years apart, which for CRPS is quite rare. And unfortunately, the ulceration could not be saved, the leg could not be saved, and this led to both legs being amputated above the knee 8 years apart, one in 2006 and the last one at Christmas 14. However, not everything has been gloom and doom in the past 14 years. I am now the proud founder and chair of one of only 2 United Kingdom charities for complex regional pain syndrome. The charity I run is Burning Nights, CRPS support, and somebody quite rightly said last night, why is it called Burning Nights? And they said, is it because it hurts more at night? And the answer is, oh yes, it does. It is like sitting in boiling oil permanently 24 hours a day. Yes, you might see makeup, you might see smiles, but this, trust me, is a very perfect front. The website is on there, and we also have a UK helpline that is available both to clinicians, practitioners, as well as to your patients and their families and friends. It doesn't just affect the patient. As Legs Matter said, it is the families and friends that are also involved. Today I'm talking about complex regional pain syndrome in general, but also focusing more on the skin issues and complications. So, most of you may know the original name for CRPS, which was reflex sympathetic dystrophy, or RSD. However, the name changed back in 1994 after the IASP conference, and they changed it and said it was more appropriate for the condition. However, the condition has actually had over 200 names in the English language alone. That does not take into account any other foreign languages or anything else. One day we might get it right. I don't think complex regional pain syndrome quite is there, but you never know. In 10 years' time, the name may change again. Some of the other names may have been Sudex atrophy, Sudex dystrophy, transient osteoporosis, Sudex morbid, you name it, we've had it. The current guidelines are actually the RSP, the Royal Society, or Royal College of Physicians 2012 guidelines, and they're taken from the ISP guidelines. They say that complex regional pain syndrome is defined as a debilitating chronic condition, and I can certainly vouch for the debilitating side of it. Pain is the leading symptom. It is very different to just a general arthritic pain. This is stabbing, this is gnawing, this is on your back 24/7. As I mentioned, it is like sat in boiling oil, but also at the freezer at the same time. Anyone touch the ice on your freezer and you get a little burn and it sticks, yeah? Little kids stick their tongues on it, things like that. Yeah, well, that burn instant, 24/7, and that's what I've had for the last 14 years. I know this doesn't look quite like that. The other symptoms that may be involved is associated with the sensory, the motor, the autonomic, the skin and the bone. So as you can see already, we're getting quite complex. It is often associated with limb dysfunction. Now on the next bit, I stress that it causes psychological distress. A lot of thinking in the United Kingdom still believe that CRPS is a psychological condition. Please rest assured, this is not psychological. This was not in my head. It didn't happen. It wasn't me. It wasn't my brain. It was my brain, but my nervous system and my brain. People still come to us today and say, people have told me, the doctor's told me it's in my head, what do I do? If I had £1 for that, I would be a very rich millionaire right now. And it often arises after an injury to a limb. They're the main common causes. There are two main types that are currently on the RSP guidelines, type 1 and type 2. Type 1 is CRPS 1 or CRPS type 1. This is what was known as RSD, or reflex sympathetic dystrophy. We do get clinicians still calling it RSD even today in the UK. This type often arises after there's been no direct damage to a nerve. So I actually have type 1 in my first leg, my soft tissue injury. So it's usually major or minor soft tissue injuries or some form of tissue injury to an extremity or to a limb. The Mayo Clinic say there's approximately 90% of people suffer with this condition or this type of this condition. The other type is CRPS 2 or CRPS type 2. CRPS 2 has been where there's been a known direct damage to a nerve. This is what they used to call causalgia, or Greek for burning, I believe. I have type 2 in my left leg because I have a sciatic nerve injury that caused the spread from my right to my left. So I'm even more, I would say weird, but I'll go for rare this morning. The third subtype was added in 1994. This is taken on for the ISP guidelines, as I mentioned. The third subtype is CRPS NOS, or not otherwise specified. Now, we have approximately 40,000 followers across all our social media, and I do not know a single person with this type. So, as to how many people have it, they say 15%. I'm not quite certain. However, it is in the guidelines, and it's basically for people that do not fulfil the current guidelines, the Budapest criteria, and they probably used to do, and they haven't actually got any other reason for it. It's not working. Yes, it is. Sorry about that. The signs and symptoms are quite wide and diverse, as you can imagine when I said at the very beginning. What I need you to remember is STAMP, the mnemonic STAMP, S-T-A-M-P. There is an extra one, I'm sorry to say, I couldn't quite fit it in. STAMP V, I call it, STAMP 5, if you like. STAMP is S for sensory, so your allergen, your hyperalgesia. Your T is your trophic, or your hair changes, your nail changes, your skin changes, and trust me, as the condition changes, your parts of your body change, and at one point I didn't even need to use shaving cream, which is amazing for women. The A stands for autonomic, sorry for any gents in the room. A is for autonomic, the swelling, the sweating. You also have general perspiration in that, and it isn't ladylike, I know, and boy, do you really sweat? My husband is really now sick and tired of standing up and sitting down. You're hot, you're cold, you're hot, you're cold. Hang on a minute, I'll put the heating on. Oh no, turn it off. And it's just a joke in our house. I think we're going to need that little, nest thing on, M is for your motor, your atrophy, your weakness, your contracture, your dystonia. And your P is your most important. That's your pain. The pain has always got to be continuing, that's disproportionate to the inciting event. So take my injury as soft tissue, it should be healed no later than possibly, 6 to 8 weeks? So 3 months later, I'm still in absolute agony going to the GP, and they're saying, well, I don't know what, there's nothing wrong with you, I can't see anything. So if you have a patient that maybe is complaining of that, think about STAMP. Your V is your vasomotor changes, so your temperature changes, your hot, your cold, and your skin and your colour changes as well. This image is actually available on the Burning Heights website, if anybody would like to visit. As you can see, this is a huge amount of signs and symptoms for one little condition that everyone says is rare. There are actually 1 in 3,800 people, or to make it simple, 288 people a week diagnosed with this rare condition. So as you can see, it's very, very wide and vast. So let's talk about the skin issues now. I will warn you, if it's okay with Heidi, there are some gruesome images later on, shall we say. So the vasomotor changes are absolutely crucial for the diagnosis, like in your stamp V. At the onset of any of the CRPS, 70% or up to 70% will remain in what they call the warm subtype. There are 3 vascular regulations: warm or red, intermediate, cold or blue. So most people will start off with the warm type. So your limb will go very, very red, and you won't need to go too near to actually feel the heat that comes off it. As the condition progresses, the actual limb changes colour from red to blue or pale, or even I've had black. And these skin colour changes will also change the temperature as well, and it will be icy cold. My limb at the last thermographic, my left one was 18 degrees. My right one was 21, which should be quite cold really, and now you see why I need the heating on. The blood vessels, they're saying, according to the research we have, the blood vessels are over-constricting, therefore it's reducing the blood flow, and then it's decreasing the tissue saturation, and eventually we have problems with tissue acidosis. Some people may also have dark outer skin, and it will look like a big ginormous freckle or a mole or something unusual. And it's this dark outer layer they're believing is the outer layer of an epidermis. It may peel, it may not, but because of the hypersensitivity patients feel, they're not touching their limb, therefore it's impeding proper skincare routine. Here, as you can see, the vast differences. I have had permission of every single person, by the way, to use these pictures. There's approximately 30 patients on these old pictures over time. As you can see, we've got red, we've got blue, we've got purple. Even in the lady in the bottom half, bottom right, is very, very purple. It's very distinct. Her CRPS was actually caused by an insect bite. John. The next skin issue we're going to deal with is the edema, the swelling. A lot of people do get an awful lot of swelling, and for me, my injury was twice the size instantly. Now, what they're saying is that the blood vessels possibly are dilating and or leaking fluid into the surrounding tissue, and that's according to the NINDS 2017 website. Unfortunately, I have to say I don't have sufficient knowledge, or there is completely insufficient knowledge about the underlying mechanisms involved in edema. I'm sorry to say. We do need more research, so anybody into research wants to have a go, we're certainly well up for it. In some cases, it can lead to lymphedema. And this is where the problem lies, because people do get misdiagnosed very quickly and very easily with lymphedema. This happens only in a few rare cases. The majority of people, it is the actual condition that is causing the swelling. In the research that we looked at, there were 5 cases I found that actually the condition progressed so much and the edema progressed so much that it ended up looking or mimicking elephantiasis. And in a lot of documents you will see skin discussed in this way. One thing I will make clear, and you need to remember, if you don't remember anything else from today, is to keep your patient's limbs moving. I know they'll want to stop moving because it hurts, but keeping the limbs moving, keeping them not immobilized will lessen any circulatory problems, and it will improve the blood flow, as you will all probably know anyway. But because they're in so much pain, they don't want to move it, touch it, or anything. As you can see here, a wide variety of edema, ranging from the hand, foot, very small, very little, to the grossly enlarged in the middle of the top level, the one with the red carpet. That actually was my leg about a month before it was amputated. these pictures I believe are available on the TVS site. Yeah. The next skin issue we're going to be dealing with is the tissue atrophy. This is where the condition progresses to the chronic stages, and the tissue atrophy may occur in quite a lot of patients. Keeping E45 and general suppleness of the skin is crucial. But again, the problem is because of the hypersensitivity, nobody's wanting to touch it, and you've got to be careful when you go near them. The skin will often become very tight, very thin, and very brittle, and it can mimic various skin conditions such as eczema, dermatitis, and other conditions like that. Obviously, the thinning of the skin will cause bruising, and it will cause cuts to appear. Skin hypoxia, the researchers said, is present in CRPS. And it was in this study that they actually said that edema cannot be the only reason for the hypoxia. What they did say, or what we did find, was for those that are primarily the cold type, which is about 30% of people, the tissue of atrophy was far more aggressive and occurred far more earlier in the actual condition stages. As you can see here, various different forms of atrophy leading on to ulceration. 3 of those people have gone on to have leg amputations, unfortunately. Obviously, in the worst of cases, skin may break down locally, and ulcers will appear next to new ulcers, and then another ulcer will appear next to another ulcer, and so on and so forth. However, one thing you need to be sure of to discount and exclude peripheral ischemia is to do non-invasive Dopplers. Now, we heard earlier about the length of waiting time for those, but if you can get patients quickly into that, the quicker they get the treatment, the better it is for these patients and the better prognosis they have. Obviously, with ulceration, infection is very, very much of a complication. And indeed, in many cases on research and people that come to us as a charity, infection is immediately following the ulceration. However, if ulceration becomes completely uncontrollable, unfortunately, amputation may actually be the only option left to that patient. I know it's not what we want to hear, but unfortunately, in many cases, because of waiting times and various other things, that has been led to amputation, upper and lower limb. The problem we're also finding is self-harming is often suspected in cases where ulceration occurs with or without infection. I am such a person that was told I had Munchausen, or my husband had Munchausen by proxy, because I had ulceration that they deemed was not proper or not correct or not following the right guidelines. So I can attest to the self-harming issue, and I am not the only person. And this is something that we want to quickly stamp out and realise and recognise and make patients and clinicians aware that it's not necessarily self-harming that's caused these problems and these ulceration. These are the worst pictures. As you can see, the breakdown is massive in some. That's actually, 3 people in that. My legs are actually in there as well. And the bottom picture with the little Inco sheet on was taken the day of amputation, emergency surgery, my second one. And I was told by a junior doctor that he would put a silver dressing on it and go home. Yeah, the main surgeon said, I think I need to see you right now. So I don't know what was said outside. So how are we actually going to assess and manage these complicated patients? Because I know we are complicated, and I'm sorry about that. In CRPS patients, as I mentioned, with ulceration in the affected limb, use the non-invasive Dopplers just to check. Honestly, it's better than not checking at all. For lower limb, check the ankle brachial pressure index, again, to warn out and weed out any ischemic elements. Due to the skin ulcers harbouring skin microorganisms, if you're taking any swabs, they will most likely, the cultures will come probably back positive. But it's only unless there is clear clinical signs of infection, high temperature and everything else, that things should actually be done about it. The appropriate antibiotic therapy in conjunction with debridements, which is the current guidelines, don't always cure the infection, and don't take it to heart. It's not your fault, I promise you. It's our little bodies. What they do say, and the RCP guidelines are saying, is the management of these ulcers is to follow the general principles of the management of diabetic foot ulcers. But again, be mindful of the fact that we're dealing with high levels of pain. On the McGill pain scale, our pain levels are 42 out of 50. 35 is approximately fibromyalgia, and an amputation of a non-important limb is about 39, 40. So we're quite high on the McGill pain scale. So be mindful of the pain levels, be mindful of any hyperalgesia, allodynia, anything along those lines. Patients will probably want to not let you near them. And I would always just give them some reassurance. I know this is teaching you nothing, but give them reassurance that you believe them, because up to that point, probably they've not been believed. So believe them and just ask them, right, okay, where can I touch? Where shouldn't I? Right, where can I go near? Because I need to do X, Y, and Z. Explain it in the most easiest way possible. I know you probably all know this anyway, but I think it's important to let you know as well in this case anyway. Obviously, if the patient is going to has got any foreign materials, any callus, any infection, any necrotic tissue, the guidelines are sharp debridement. Having been through 5 of them, I can attest the fact that within 24 hours, it's all back again. The slough, the infection, everything is back within 24 hours. So it doesn't always cure it. However, that is the current guidelines. Weekly debridements, again, should be considered for the deep and the sloughy wounds, like you saw on the last couple of slides. Again, reiterate, they don't always work. It's not your fault. Pressure relieving dressings, such as felt foam, low pressure garments, open shoes. I know it's probably not standard, but that's what is probably the most easiest for these patients. Dressings that promote the moist wound environment, again, caring for chronic wounds, as we heard in Legs Matter and the other speeches this morning. Silver and iodine impregnated dressings, again, used, yes, in the early stages, but if you've got the chronic stuff and the chronic wounds and the slough and the goo and the exudate, and you name it, probably it's not going to work. So again, don't be too disheartened, and trust me, it's not the patient's fault. I know we like to get blamed, but you know. Compression bandaging is the other very, very common thing that nurses like to come to patients like me when I had legs and say, it's going to disperse the tissue fluid. They'll use the wool ones. However, you can't come near me because I've got hypersensitivity, so much so that even if wind blows on me, it's like I'm burning in hell. Sorry, can I say the word hell? Sorry, thanks. I've said it now, sorry. Patients may not be able to withstand the bandaging, and I know that's probably contrary to guidelines, but if you have to leave it, unfortunately, you may have to leave it. So, conclusions. I've got the 5 minutes. Yeah. Complex regional pain syndrome, or CRPS, as you know, as you can hear, is an extremely difficult, complex condition and hard and difficult to treat, but also to diagnose at any stage. The best results are obviously obtained the earlier the diagnosis is formed and the quicker treatment can start, because as soon as we can get the treatment in, the window is actually only 3 to 6 weeks from the actual injury or illness, which, as we can all probably guess, the NHS is not quite there yet. But I have heard of patients being diagnosed in that time. It's very easily misdiagnosed, especially where there's skin conditions. As you saw in those images could be pretty much a lot of conditions. There is no single pathophysiological mechanism of explaining this condition. What they do say is there are multiple mechanisms involved. Amputation may be the only option left to that patient if gangrene, ulceration, infection. Blood transfusions may actually be needed during amputation. Now, that sounds weird because they're rot from the outside in. So my blood flow, I had 11.5 units of blood and it took 12.5 hours, my first surgery. My second surgery took 8.5 and 9 units of blood. So yeah, you probably sometimes need it. And the final thing I want to get through is that the multidisciplinary team is essential for CRPS patients, not only for helping you to deal with skin issues, but for their safety and guidance as well. Thank you very much for listening.
We've got time for a couple of questions. Has anybody got a question for Victoria? Okay.
Hello.
Where's the mics?
Carol. There. Just the lady, the nice white filly. Sorry, that's wheels on it. Yes. Cause I have a safety nightmare.
We're going to have another injury there.
It's all right, I'm a barrister, I'm all right. Yeah. Well, you're all right, you're safe. Everyone's safe. Hi.
Hi, I'm Carol Bartley from the University of Salford, and I'm actually an occupational therapist, so hearing about all these things today is really, I'm learning so much. What I wanted to know is where are you now in terms of your function and everyday living? Are you still getting pain, or are you, now that your legs have been amputated, has that got rid of all of that, or is there still areas that's still affecting you?
Yeah, no, I totally understand. My quality of life has gone from 0 or minus 10,000 to 100%. Yes, I don't have prosthetics, so in the rehab world, I actually have failed to rehabilitate. However, I don't like that term, so never mind. I'm not having it. So I don't have the capacity to walk. I have wheels, they're my feet. I do have a way better quality of life. It has solved the ulceration for now. Unfortunately, it's looking like my right one, which is the first one, that actually had revision surgery. It took 18 months to heal because when CRPS occurs, it's slow healing. Everything slows down by exponential amounts. So it's looking like, even though it was done 12 years ago, it's going to have to be reshaped. So it's going to look like, because I've got ulceration again. But in the main, yes, I've got pain. I've got 57 tablets a day. It used to be 92. I'm on 57, and I'm on the dreaded opiates. Yeah. But actually, they allow me to function and be here and be as competent as I am today. Yeah. That's the humming, by the way. Yeah. So, but even though I'm an amputee, I don't actually advocate on behalf of amputation. It doesn't solve the problem. It's there. It's the nervous system and the brain that is the problem. And I know that sounds very strange coming from a lady with no legs, but for me, mine was a sepsis. Mine was a life or death choice on both. I either lived or died, and I chose to live. Some say safe, but you know, that's me. But yeah, I'm in pain, but nobody will ever know in here.
Okay. I think Victoria is able to stick around a little bit. She's shooting off to Birmingham today to speak there tomorrow, so she's a very busy lady. I know John's got a question, but he's also speaking now, so he'll have to wait until the end. Thanks very much, Victoria. Just to remind you, you can pick your leaflets up next to Michael there at the front.